Let's now introduce Dr. Salma Afifi, the Senior of Medical Epidemiologist and Public Health Consultant for Ministry of Health and Population and WHO Egypt. Dr. Salma, please start your presentation. Dr. Salma have many positions, have a Master of Epidemiology and Diploma in Occupational Medicine from Ain Shams University, and have also certified from USA EWAR University in Zoonotic Disease Public Health Laboratory and Applied Epidemiology. Dr. Salma, are you here?
Yeah. Thank you, Dr. Hanan, for the introduction. And I will go on and share my screen. So, for the sake of time, I will, in this lecture, I will try to discuss the importance of an early warning and response system and the components of the system. And I will present a simplified form of the WHO EWAR system and steps of preparation and implementation of the early warning and response system and types of surveillance system working in emergencies, which are the indicator-based surveillance and event-based surveillance. As we all know, the population affected by the emergencies are continuously at risk of outbreaks and of transmission of epidemic-prone diseases and other public health events. Emergencies, this is because the emergencies produce many risk factors that promote the emergence and transmissions of the communicable diseases and public health events, including the food and water insecurity, progressive loss of livelihoods, disruption and or breakdown of the preventive or curative health services, and the mass displacement that usually follows into camp-like settlements with crowded population and neighborhood, unsanitary neighborhood. In Gaza, all these risk factors are really, as Dr. Tamer and Dr. Shadi just presented, there is a breakdown of preventive and curative health services. There is a food and water insecurity. There is progressive loss of livelihoods, mass displacement, and the spokesperson of the Ministry of Health and Ministry of Health, Palestinian Ministry of Health, just announced that cases of cholera and hepatitis A virus outbreaks reported in the camps and in the emergency area. To clarify the importance of early detection of outbreak, this graph shows the classic events that occur usually in an outbreak. So in day one, the case occurs. And in day 3, usually the case goes to seek health care. And in day 13, for example, the healthcare facility reports to the Ministry of Health. And then the ministry sends a team to investigate the event and collect samples. And in day 21, the lab results usually appears, and the response started in the 25th. In the 25th day. So the opportunity to control the people or the cases is very small, as you can see here. The other scenario is if the first case occurred and we discovered this and immediately reported this, confirmation will occur, for example, in day 5, and the response started without investigation and without waiting for the lab response. So in this case, the opportunity to control all these number of cases is very high. So the early warning system, the WHO has developed a system to strengthen early warning and alert system, which is called EWAR. to reduce the excess morbidity and mortality in cases of from the priority epidemic-prone diseases and public health events. The early warning system includes 3 elements, which are the early warning, the alert management, and the response. For the early warning, it's the rapid detection of signals that may indicate potential acute public health events. For the alert management, it's the process of managing all incoming information to decide if this response, or if a response is required to mitigate these public health risks. And the response is the public health action triggered by the detection of this alert. This diagram shows the 3 elements of the EWAR system, which is the early warning here and the alert management, and then the response. Lastly, the response phase. I will talk about the preparation to implement an EWAR system. The first thing is, as we discussed, that the current situation is in Gaza now is the surveillance and healthcare infrastructure is destroyed. And there is weak national health authority governance over the healthcare and the preventive sector. So we need to start with an assessment of the situation to discover or to detect the capacity of the routine surveillance system, and if there is any coordination, a network of coordination between the government and other partners, and the capacity of the lab network, if there is a capacity now, or any laboratory is still working, and the linkage between the surveillance and the response capacity. So if the surveillance detected any signal or alert, is the response can be done quickly, and the disease data collection standards, if there is still disease or data collection standards and investigation tools available. Then the components of the assessment is we need to start with determining the geographical area and the population that will be included in under the EWAR, and to identify the key sources of information and the priority epidemic-prone diseases and conditions, and the environmental hazards and risks, doing risk assessment, and mapping the existing surveillance and response capacities. So, and lastly, to develop an actionable recommendation to targeted towards the EWAR implementation. We'll talk about the geographical area and population determination now. We need to put a map. This is an example of a map that include any vulnerable group. As you can see here, the population, the area where the population, the number of population in each area, and the number of population that displaced, and the healthcare facilities available. So this mapping will help to determine the boundaries of the geographical area that the surveillance will cover. Sources of information. So we need to collect any information about risk assessment that have been done before for the epidemic-prone diseases and the conditions with potential to cause an outbreak in the area. And we need to prioritize, depend on the type of the event and the vulnerability of the population based on the agent, host, and the environment factors, and the likelihood and potential of the impact, the potential impact of each potential disease that we need to prioritize. This is the classic list of epidemic-prone diseases in emergency situation, which include the acute watery diarrhea or cholera. This is the acute watery diarrhea is the syndrome, and cholera is the disease. Bloody diarrhea and shigellosis, measles, meningococcal meningitis, COVID-19, human influenza. This is the classic emergency epidemic-prone diseases in an emergency situation. So the epidemic-prone diseases, especially those caused by recent outbreaks, we need to investigate or to collect the information about this. and also the endemic diseases that may increase and cause an outbreak in the area. For example, the acute respiratory illness or malaria, if the area has been attacked with outbreaks of malaria before. For the host, we need to investigate or assess the age of the population that under surveillance, because diseases, the epidemic-prone diseases for childhood is different from those of old ages and adulthood. We need to assess the malnutrition, the status of public health of the population, and the population vaccination status. So the coverage, for example, for the measles, and coverage of other diseases, for example, COVID-19 or influenza. This is the host. And for the environment, we need to assess the overcrowding, the level of access to clean water and sanitation, and the level of and the quality of the shelter they sleep in or they live in, level of access and the quality of healthcare, and presence of any vectors, for example, the mosquitoes or rats. This will help us to decide or to prioritize the epidemic-prone diseases that will be targeted by the EWAR system. For the environment, we need to assess the population displacement, the specific factors, the size of the population in the area, the overcrowding, the lack of clean water, as we mentioned, child and adult malnutrition, lack of access to preventive and curative health care, and vectors, as we just mentioned. This is the risk assessment matrix. So in the y-axis, here is the likelihood of the event to occur, and in the x-axis is the potential magnitude and the impact of the health problem that we are investigating. So if, for example, the healthcare, the epidemic-prone disease is most likely to occur and is mild or minor, it will be in the, for example, yellow area, and so on. If it is severe and can occur, likely to occur, it will be in the red area. This is the outcome or the result of this matrix. So we can arrange the diseases like this, and we can do risk assessment, immediate risk assessment, for example, for 1 month, or late risk assessment. This is because the situation is liquid and it's changeable. So, for example, this is in Ukraine. So they decided that COVID-19 is the most important or the most risk they will face, or the most important disease, epidemic-prone disease. This is because although it's decreasing trend, but it is very high level of incidence, and bed occupancy there is very high, and the ICU care is very high occupancy and limited oxygen and supplies. So they think that this disease has high risk in the current months, but later, after 2 or 3 months, it will be in the orange area. After that, we need to develop a list like this to put the priority diseases that we need to put or to target in the EWAR system. We have syndromes like acute watery diarrhea, and diseases like cholera, dysentery, hepatitis A, and so on. But this list is too long, so we need just from 8 to 12 to prioritize these diseases, to cut it short into 8 to 10 to 12 diseases maximum to target in the EWAR system. So how to prioritize these diseases? We need to develop criteria. For example, the likelihood to occur, the morbidity, the mortality, the severity, level of severity, epidemic potential, population vulnerability. And there is a tool has developed online by the WHO which I included the link here in, and it's clear here that this is the criteria one, and this is the disease. The first disease, it's criteria one where let's suppose it's morbidity. So the first disease is 3/10 morbidity, can cause morbidity, but not too much. Disease 2 can cause 5 from 10. Disease 3 is 7 or 8 from 10, and so on. And then this tool will prioritize a number. You mentioned, or you asked them to prioritize 10 or 12 or 8 diseases, and they will produce the list to you with which in descending manner. Implementation of the EWAR system. First thing is the National Public Health Authority need to do something, or need to start the implementation by identifying the partners who can be including the focal points at different levels. For example, at healthcare facilities and NGOs, or at peripheral level, at central level. So we need to, the Ministry of Health or the National Public Health Authority need to identify the partners, and then to develop an implementation plan. So starting with the training, for example, or starting with developing the tools of data collection, or starting with the assignment of personnel. So there should be an implementation plan. And then the authority should draft and agree on standard operating procedures for outbreak preparedness and response, and agree and pilot and disseminate the data collection tools, and agree on a plan for data analysis and reporting, and develop and disseminate the epidemiological reports to all partners and all stakeholders, and to coordinate the implementation, including training and supervision of the key staff, and monitor, after that, to monitor and evaluate the performance of the EWAR system regularly. There should be a coordinator or a lead epidemiologist that will oversight and supervise all the system at all levels, and support the training and supervision of the key staff, and support system implementation and data analysis, and contribute to the risk assessment and alerts and contact tracing and outbreak investigation and active and passive case finding and other rapid response team responsibilities, and produce reports as needed, and to develop or to support the logistics. Surveillance officers at the peripheral level should receive and monitor and verify the alerts, and contribute to the risk assessment at their areas, and coordinate the active case finding and contact tracing, and they should have a strong tie with the community under surveillance to be able to communicate and to identify or get the reports from the population and the community, and configure and management the data system. We have two surveillance systems which are complementary and should be done in the event of EWAR system implementation. These are the indicator-based system, or IBS, which is a systematic collection, monitoring, analysis, and interpretation of structured health-related data, which are the indicators produced by health facilities or other defined sources. This is the indicator-based surveillance, which is the IBS. And the event-based surveillance, it is an organized collection, monitoring, assessment, and interpretation of mainly unstructured ad hoc information. So including rumors, media, or anything. And this system is developed to early detect or early suspect any event or health of public health importance. The indicator-based surveillance, or IBS, focuses only on small set of, as we mentioned, from 8 to 12 priority diseases or conditions, and limited to public health hazards for which a public health response can occur. So there is no meaning if I cannot target or I investigate a health problem that I cannot respond to. So reporting in this IBS is usually in using standardized case definitions, and we will talk about this shortly, and should identify time of reporting and for each priority disease when this should be reported, and we'll talk also about this shortly, and ensure data analysis, regular data analysis and interpretation are undertaken at all levels of the surveillance, and establish multi-directional feedback loops to everybody or to every partner in the surveillance, and the community should be engaged in this. This is a case definition, example of case definitions of that is being used in IBS. For example, suspected cholera or acute watery diarrhea is any person 5 years or older with severe dehydration or death caused by acute diarrhea, which is 3 or more abnormally loose or fluid stools in the past 24 hours. But during the cholera epidemic, any person 2 years or older with acute diarrhea, which is 3 or more abnormally loose or fluid stool in the past 24 hours, with or without dehydration. This is a classic case definition of the acute watery diarrhea or the cholera, suspected cholera, and you will find a lot of these definitions in the WHO and in the CDC sites. This is another example of the jaundice, for example, acute jaundice syndrome, which is, we target hepatitis A outbreak because hepatitis B or C usually does not cause large outbreaks. So the acute jaundice is acute onset of jaundice, which is yellowish or of whites of the eye or skin or dark urine, and severe illness with or without fever and the absence of any known participating factor. The frequency of reporting in the IBS is usually on weekly basis, but should be complemented by an immediate reporting for the diseases or conditions with a 1 case alert threshold, which if 1 case just appeared, so it should be immediately reported and immediately notified. The frequency of analysis of the data of the IBS is usually also on weekly basis, and is done to see if the number of cases has crossed or crossed the alert threshold or not, to start the investigation or to start considering a signal to detect if a signal is being reported or not. The data collection tool in the IBS should include the source of reporting, the location of reporting, the nature of the hazard or the disease, the date of the event, the onset date of the symptoms, number of cases and number of deaths. This is at minimum, signs and symptoms, and number of people potentially exposed or affected by this disease, or the risky group. This is there are 2 types of data usually collected in the IBS: the aggregate data and the case-based data. The aggregate data is just numbers or sum of numbers, but not reported individually. It's used for usually from the outpatient health facilities, and it can include the total number or the number by certain groups, for example, gender or age group. Should I stop, Mohammed? Well, Mohammed, is it going well?
Alhamdulillah, alhamdulillah. Thank you so much. Thank you.
For the case-based cases, the individual cases are reported, and it's often used in the inpatient facilities where the details of each case, the clinical presentation, are readily available. The analysis of the case-based is usually by time, person, and place. For example, for the health and should include the unique identifier for the case, the lab results, the health facility, the demographics, and the symptoms, and the report date of reporting, date of occurrence, as we just mentioned, and it's collected in a line list or a sheet, for example, Excel sheet. For the aggregate data, it's good because it's easy and save time and resources, but it does not allow for detailed analysis of the data, whereas the case-based reporting enables the analysis of the disease data by time, person, and place, and see to help inform the response and risky group, and how to prioritize the risk group or prioritize the intervention. How to define the alert threshold in the IBS? The threshold is defined as a predefined number of cases that, when reached or crossed, it generates a signal. We have 3 types in the IBS of the threshold. The fixed value, which is if we don't have any historic data, so the threshold is set at absolute value, which is 5 cases, 6 cases, whatever, in 1 week, or whatever, according to the agreement or the discussion or the risk assessment, as we just mentioned. And the moving average, which is the data from the past weeks. So we calculate, for example, 7 days, the mean of the last 7 days, and put this and see if this is crossed or not. But and in case of we have historic data for the endemic diseases, we can set and calculate the historic data, the mean of the historic data, and add the standard deviation or whatever, and we can see. We can use this to see if there is a signal or not. This is an example of the fixed value. For example, for the measles, acute hemorrhagic fever, acute neonatal tetanus, typhus also, a single case will be considered as an alert. For the acute watery diarrhea, 5 cases in more than 5 years of age group in 1 location in 1 week, and so on. And these are there is a lot of these definitions in the WHO and in the CDC. This is how we put the information into graphs and clarify this information. So the dotted line. The dotted line is the 7-day rolling average, or rolling or moving average, and the red line is the 5 cases that, if it is crossed, we consider it an alert or a signal. And these are the column here are the number of cases, the daily number of cases of acute watery diarrhea. So I think it's clear that it was crossed from here. It crossed the rolling average, and crossed the fixed value. Now we are going to talk about the second type of the surveillance, which is the EBS, or the event-based surveillance. As we mentioned before, it's the organized collection, monitoring, assessment, and interpretation of unstructured and ad hoc information. This is important for early detection of potential public health hazards, as we just mentioned, which may represent an acute risk to human health. The reporting sources could be anyone, from health facilities, from communities, from media, for other stakeholders, or anyone who can work with or who can report, depending on the facility or that available for reporting. It's not based on case definition. It's just anyone who thinks that this is there is an unusual event, as I will mention very soon. This is important because it reaches beyond the health facilities. It's not just, it's not like the IBS, which depend mainly on the health reporting from health facilities. What should be reported, as we mentioned? Any acute health event caused by a variety of infectious, non-infectious, environmental, or any hazard, any biological, chemical, physical, it's typically reported within 24 hours. Who should report? There should be a professional network, for example, from healthcare workers, pharmacists, laboratorians, volunteers, government and NGOs, teachers, religious leaders, also maybe animal health and the environmental sectors, traditional healers or traditional birth attendants, especially where, including especially where the healthcare traditional services are unavailable or destroyed or not present, like in Gaza. The media sources, the newspapers, the radio, the social media, and other, for example, internet based or other, and the public, of course, the general public. The types of events that could pose a risk for public health could include single case of a rare disease or unusual or severe disease or condition, or unusual and unexpected cluster of diseases or deaths in a common area, or the diseases or conditions that affect many people. There is a lot of people having the same symptoms, information about new unusual disease or condition, and so on.
Dr. Salma, time, please.
نعم.
time.
طيب يعني أنا هخلص. طيب طيب فاضل كام دقيقة يا دكتورة؟ 5؟
actually احنا exceeding، بس حضرتك ممكن 5 دقايق يعني.
طيب
slide out to.
طيب this is the IBS compared to the EBS. There is, as we mentioned, 3 components. The first 3 is the early warning, and the second is the management of alert, and the third is the response. So here in the IBS, the alert is when the threshold crossed, and in the EBS, if the positive triage occurred or the information came to be true, and the signals is going to be verified if comes from both the systems, and then the intervention, a risk assessment, a quick risk assessment is done to identify the alert, and then the response will follow. Oh, there's a lot. I will talk about the response here. There is 2 types of response: immediate and generic response measures, and disease-specific response. For the immediate and generic response, for example, this will implement a community engagement and consultation with the community. They need to be involved in these generic and control measures. For example, and this is general, for example, enforce the infection control and prevention, just like Dr. Shadi I just mentioned, and if water or foodborne transmission or on environmental agents to improve the sanitation, if human to human isolation, and so on. And the disease specific, if the specific disease is confirmed, so we can, for example, do vaccination for meningitis and measles and cholera and diphtheria, and safe water for shigellosis and hepatitis A, and to prompt diagnosis and treatment of cases to prevent the spread of the disease and control of vector if there is a vector. I will stop here because of the sake of the time, and thank you for your listening.
Thank you very much, Doctor, for your detailed and very illustrative information. Actually, you covered it very nicely. And I also want to add the basic measures we undertake as the public health for cases, control, environment for each category at the same time. As you already presented, for cases, it is very important to put diagnostic criteria and the case detection to be well known and understood by all. Also, the management, the isolation, and the management for cases, very important. Number two, the contact tracing, also as you presented in details, and the measures for contacts regarding vaccination or chemoprophylaxis, immunoglobulin, according to the condition and the disease. And the environment aspect, which is already presented and touched by two topics, the water and the sewage. So it's very important to remember this approach and follow to avoid and protect against the occurrence of outbreak, also for controlling any occurrence of outbreak to prevent its upgrowing to be epidemic. Thank you very much, Doctor, and waiting for any question also at the end of the session, we will ask you.